And today I'll be talking about POCUS and pericardial effusions. I have no conflicts of interest to disclose. And today we'll be discussing the role of cardiac point-of-care ultrasound, reviewing the pericardium and its properties, reviewing some bedside ultrasound technique to complete a cardiac exam. We'll be looking at some different causes and pathophysiology of pericardial effusions and ways to identify tamponade physiology using ultrasound techniques, as well as understanding some limitations of POCUS when we're trying to evaluate cardiac conditions. So we'll start with a case, and then we'll kind of come back to the case a little bit later. But this case is about a 3-month-old male with the double inlet left ventricle, actually, with a hypoplastic RV. Now, after a Norwood with a 4.0 BT shunt, is presenting with persistent desaturations at home. He was intubated soon after admission for hypoxia to the 30s with concern for a clot in the BT shunt, and was taken emergently to the cath lab. He was found to have stenosis of the distal shunt that is now stented in the cath lab, and he returned to the CTICU intubated and mechanically ventilated. Approximately 40 hours after the cath lab, he starts to develop progressive hypotension and tachycardia. His CVPs have increased from initially being 7 to 8 millimeters of mercury to 16 to 18 now. His pulse pressure continues to narrow, and he starts developing a metabolic acidosis with a pH of 7.19 and lactate increasing to 7.2. His creatinine also increases from 0.6 to from 0.3 to 0.6, sorry. Trying to just adjust my screen. Liver function tests came back, and his AST and ALT are now elevated to the 3000s. His INR is also elevated at 3.8. The team at bedside now gives albumin 5% bolus, 5 cc's per kilo times 2 to support the blood pressure, which is continuing to decrease. And the patient is now started on epi and vasopressin for hemodynamic support. The chest x-ray, as you can see here on the left, is showing increasing cardiomegaly, and a point of care of ultrasound is done at bedside by the PICU fellow. This is what his point of care ultrasound looks like at bedside. So this is a patient with single ventricle physiology who recently had a cath procedure, and now his point of care ultrasound shows a global pericardial effusion. So we'll come back to this case a little bit later and go through some of the rest of our talk at this time. So just a question for the group here. What is the next best step based on this POCUS image? You can use a QR code there to answer these questions. And we'll be able to answer some of these questions as we go along in the talk today. But your options are, should we call IR, prepare for pericardiocentesis at bedside, increase the patient's epi drip, give a 25% albumin bolus followed by Lasix, or continue to monitor with supportive care. And I think everybody's going to agree that the last option is probably not the best option at this point. But we'll talk about why B is the answer, actually, to prepare for a pericardiocentesis at bedside. So we'll start off by talking about focused cardiac ultrasound. So focused cardiac ultrasound, also known as POCUS, is a bedside ultrasound exam that we can do to identify some sort of cardiac pathology, whether it's a valvular issue, a hemodynamic issue, structural abnormalities that can allow us to do early triage and management at the bedside. It can be done by us, bedside providers, to evaluate the pathophysiology at the point of care. And that makes it very different from a limited and comprehensive echo. It's used in ICUs and ERs to evaluate different presentations and pathologies. And the goal, of course, is to provide timely and repeatable diagnostic information when we need it. So if you think about your focused cardiac ultrasound, The numerous advantage too is, there are numerous advantages, but some of them include that it's repeatable, it's feasible, it's non-invasive, it's prompt, and it's rapid. And of course, there are several different indications for a focused cardiac ultrasound, including evaluating a pericardial effusion like the one we saw, evaluating if there's cardiac tamponade, looking at systolic function of the left ventricle, looking for a pulmonary embolism and RV strain, assessing for volume, looking at valvular abnormalities, and then management of a cardiac arrest or anything procedural like a pericardiocentesis. So now that we know what we can do with the cardiac ultrasound, we can now focus a little bit on the pericardium. So the pericardium is a fibroelastic sac that surrounds the heart. It is hyperechoic, which means that it shows up as a bright white rim on ultrasound, as you can see next to the arrow on the picture on the screen. And it's easily recognized both anteriorly and posteriorly as the sonographic border of the heart. Normally, there's a small amount of physiologic fluid, depending on the size of the patient, anywhere from 5 to 50 mLs of fluid that surrounds the heart to assist in function and protecting it against infection. And when this fluid volume increases, an effusion can easily develop within that sac. There is an outer fibrous parietal layer and an inner serous visceral layer, known as the epicardium. Pericardial effusions can develop rapidly, whether that's acute or more gradually, known as subacute or chronic effusions. Normally, though, this pericardium can stretch to accommodate small increases in pericardial volume. The amount of stretch of this pericardium is actually related to how quickly this effusion develops. And the ability to stretch is actually greater with slower developing effusions. So in these kids who have chronic conditions that can yield pericardial effusions, they slowly generate this volume accumulation in their pericardial sac, and actually their ability to tolerate a larger size effusion is more than other patients where it's actually it's more acute. When you have increasing accumulation of this fluid in this closed space, it'll eventually result in an increase in intrapericardial pressure, regardless of how quickly it develops if it's not addressed. And so, normally this can stretch, but when it reaches beyond a certain point, there's not much more compensation that they can do because there isn't that much room. So with any uncomplicated pericardial effusions, excess fluid initially accumulates in the most dependent areas, typically posteriorly or inferiorly around the right atrium, which is actually normally the chamber with the lowest pressure. So that's where these like to accumulate more so. Based on how quickly or how slowly these pericardial effusions can develop, patients can actually range from being completely symptomatic to having severe hemodynamic compromise and leading to cardiac arrest. So as we just talked about, the pericardium has some degree of elasticity, but once that elastic limit is reached, the heart needs to compete with the intrapericardial fluid for volume. So as cardiac tamponade progresses and as this effusion starts to get bigger, the cardiac chambers actually become more emptier, they become smaller. The chamber diastolic compliance decreases, and as a result, these chambers are unable to fully relax and unable to fully fill. When you see impaired filling, impaired cardiac filling, you actually see impaired heart function. And as a result, you can see cardiac tamponade and subsequent obstructive shock. So the pericardial volume serves as an external force that is actually preventing adequate cardiac filling. And we'll talk about tamponade physiology a little bit more in detail later. So why we're talking about POCUS today is because it allows for this rapid non-invasive diagnosis of a pericardial effusion and cardiac tamponade at the bedside by us as providers. So we'll go over some of these techniques and management principles in the next few slides. And then, of course, we all learned about, Beck's triad, hypotension, JVD, and muffled heart sounds as being the key features of pericardial effusions and tamponade. However, in our pediatric population, it's actually very rare to see see the combination of those symptoms. So this is an example of an ultrasound with a patient with pericardial effusion. On ultrasound, pericardial effusions are seen as an anechoic or a black band that encircles the heart and separates the bright white, highly reflective parietal pericardium from the heterogeneous gray myocardium in the middle. There's free-flowing pericardial fluid that initially accumulates posteriorly, and that is identified as the most dependent area of the pericardial sac. Patients who have recurrent pericardial disease, or those who just had cardiac surgery or cath procedures, for example, the pericardial fluid can actually be loculated in those situations, since the pericardium was or potentially could have been involved in the procedure. And it doesn't necessarily flow freely when it's loculated with changes in patient positioning. Whereas conditions like lupus or autoimmune conditions or malignancies, you actually normally see unloculated, simple effusion that's globally distributed. And then, of course, hemodynamic compromise can occur even with a small amount of loculated fluid, especially depending on where it is loculated and what chamber of the heart it's compressing. And so therefore, recognizing the risk factors of developing effusions and identifying these at the bedside is all the more imperative. So when we talk about effusions and pericardial effusions, they can be classified in several different ways. Is it a small effusion that's less than 10 millimeters, moderate effusions that's 10 to 20 millimeters thick, or a large effusion that's greater than 20 millimeters? Is it transudative or exudative? This difference helps us distinguish between different causes of the effusion. For example, transudative effusions are seen with conditions like heart failure or renal insufficiency or low albumin levels, whereas exudative effusions are usually associated with pericarditis or infection or autoimmune conditions or malignancies. We can look at the onset. Since when has this effusion been present? How is it distributed around the heart? Is it in a dependent area posteriorly, or is it global? Is it a simple effusion or a complex effusion? This may actually help determine how the effusion needs to be drained and in what setting, and who do we need to call to bedside. In most cases, the majority of patients who have a pericardial effusion are not really found to have an identifiable cause of pericardial disease. There are several other causes, as you can see on this list here, of pericardial effusions. For example, acute pericarditis. Many viruses like Coxsackie, echovirus, adenovirus, EBV, CMV, influenza, parvovirus are associated with acute pericarditis. Bacterial infections like TB, staph, strep, H flu can cause pericarditis. Autoimmune conditions like lupus, for example, is a common cause that we tend to see quite a bit here, and just recently had a patient with a moderate to large size effusion causing tamponade with a new diagnosis, lupus. Post-myocardial infarction, post-surgery, post-cath procedures, post-IR procedures, any sort of sharp or blunt chest trauma, malignancies, mixed edema, aortic dissection that could be extending to the pericardium, renal failure, or mediastinal radiation. So those are some causes that we consider. Now let's talk about different techniques for the focused cardiac ultrasound. So standard two-dimensional images of the heart can be obtained from three main different locations. 4 locations actually, or 3 locations, but 2 in different axes. So you have the parasternal location, the apical, and the subcostal or subxiphoid. And your parasternal view can be obtained in the long axis and the short axis. So we'll briefly discuss these techniques, which allow us to identify pericardial effusions rapidly at bedside. So on this slide here on the left, you'll see various imaging anatomic planes that we refer to along which the ultrasound beam is aligned. So all objects have a long axis and a short axis unless they're perfectly symmetric. The imaging planes of the heart are named in relation to the axis of the heart. So the long axis plane, which is the blue plane here, bisects the heart vertically from the left ventricular apex to the aortic valve at the base of the heart. And this is the blue plane right here. It allows us to identify effusions, issues with the aortic outflow tract. Then you have the short axis plane here, the green one right here, which is perpendicular to the long axis and shows cross sections of both ventricles. And we're going to see some examples of these to explain it better. But it does allow us to assess global function of the heart in the short axis view. The apical plane in the purple extends from the apex to the base of the heart and bisects the tricuspid valve and the mitral valve. In the middle, on the top, you'll see that we use a low-frequency phased array probe. These are best for cardiac ultrasounds. It's a small footprint transducer that allows optimal imaging for us to look in between the ribs to minimize the rib shadow and to best optimize our intercostal images. And then when we're holding this probe, we always talk to our trainees, you're holding it as if you're holding a pencil while resting your medial palm on the chest wall, allowing for easier manipulation of the probe, better control of the probe. And of course, ideally, the patient is supine at the level of your waist with the head of the bed slightly raised to 30 degrees. The patient can also lie in the left lateral decubitus position, which is, how they have our adults get positioned to enhance viewing of the apical four-chamber view. However, the wonderful population we work with doesn't always allow that. So imagine telling a 2-year-old, lie on your side so I can get better imaging, and it's more convenienced for me to get optimal images, and doesn't really work well with us. So, we do what we can at bedside to be able to get these views as best as possible. The parasternal long axis view. So ideally in this situation, you can see here on the bottom left, a red dot, which is where our indicator on the probe is faced towards, and then this purple box is where our probe is aligned. So the patient ideally should be placed on his or her left side on left lateral decubitus position. And we place the probe at the left parasternal border between the third and fourth intercostal space with the probe position indicator, or the red dot, pointed to 11 o'clock towards the patient's right shoulder. With small tilting of the probe and rotation movements, you can achieve an alignment of the imaging plane with the long axis of the heart. So you can tilt the probe to get better, to get different images. As you can see on the right side, those ultrasound images are obtained as you're tilting your probe back and forth. And we can use this view to look at the structure, look at the function of the chambers, look at the valves, valvular function. You can also look at the LV posterior wall with this, the intraventricular septum, which is nice to look at in cases where you have RV strain or RV failure, and is my septum bowing into the LV. And you can also identify a pericardial effusion. So here is the parasternal long axis view here, just labeled what we're looking at. The RV is at top, your intraventricular septal right before or right below, your LV below that with your aortic outflow tract, and then your left atrium at the bottom. Your inferior wall is right below that, and your pericardium is at the bottom of your parasternal long axis view. So if we're looking at an effusion development, that's likely where you're going to see it in a parasternal long axis view. The parasternal short axis view, so essentially you're at the same position. Your probe is placed at the left parasternal border between the third and the fourth intercostal space, but you rotate the probe now pointing towards 2 o'clock, and your indicator, which is the red dot, is pointed towards 2 o'clock towards the patient's left shoulder. And so we're rotating the probe clockwise until the true short axis of the ventricle is seen, usually about a 90-degree or so rotation. And this is what we're looking at. So we'll look at the ultrasound image of what it would look like. The transducer can be tilted upwards towards the head or cephalically to see your aortic valve and your pulmonic valves a little bit clearly, but this is your short axis view at the aortic level. where at the top you see your RV outflow tract,
Right. Okay.
your PA on the right side, your right atrium at the bottom, and your left atrium all the way at the bottom on the right. But it's a great way to take a look at your aortic and pulmonic valves and tilting back and forth. So this is the aortic level. This is the mitral level. So your transducer is systematically tilted downwards to visualize the mitral valve, as you can see here. And this is the papillary level. So you tilt even more downwards of your probe that's still facing 2 o'clock towards the patient's left shoulder, but you're tilting the probe a little downwards caudally to see the papillary muscles of the left ventricle, which you can see labeled here. So now the apical 4-chamber view. So the patient, to obtain a apical 4-chamber view, the patient is placed in a more supine position now, and the transducer is placed over the apex of the heart with the index point to the patient's left shoulder. So usually you can start between the 6th and 7th rib spaces in the mid-axilla and move between ribs either medially or laterally, depending on the patient's apical location, because we have to look for it when we place the probe on. Your standard apical view is, as seen here in this image, shows essentially an upside down heart with the ventricles located at the top of the image, the atria at the bottom. The right side of the heart is on the left of the screen, and the left side of the heart is on the right of the screen. And this allows you to get more of a global assessment, a subjective assessment of the cardiac structure and the function. It helps to provide volume status of your left atrium, your left ventricle, and also can be used to identify fluid within the pericardium. And then the last view we'll talk about is the subcostal and the subxiphoid view. So to obtain a subxiphoid view, the patient should be laying supine. The transducer is positioned, as you can see here on the left, below the sternum with the index point oriented towards the patient's left side. It may require some pressure with anterior angulation of the probe, as your goal is to ensure that the ultrasound beam passes underneath the sternum. So many times we will take the probe, kind of feed it into the sternum, and then dig it below the sternum, which can cause some discomfort. And is not as easy to do in a crying toddler as you're trying to get a great subxiphoid view. Images are best on inspiration, since that brings the heart closer to the transducer by coming down. The right heart is closer to the transducer on top, and the left heart structures are lying posteriorly and laterally, as you can see here in these images. When you're looking at the subcostal subxiphoid view, we're able to see the atrial, any sort of atrial septal defect or a ventricular septal defect, and it also will allow us to see pericardial effusions as well. So those are the different views that we can use. So let's talk about cardiac tamponade, because that's what we're trying to either prevent or manage when we're using POCUS at bedside to evaluate pericardial effusions. So what can you expect to see with cardiac tamponade? The question is, what actually happens when the intrapericardial pressure becomes so high that it exceeds the intracardiac pressure? Right? So in those situations, when your intrapericardial pressure is higher than your intracardiac pressure, you have impaired filling, your chamber is collapsed, there's decreased cardiac output as a result of decreased forward flow. And this can be seen, like we've talked about, in post-cardiac surgery patients, post-cardiac CATs, trauma. It can be associated with malignancies, infection, pericarditis. Then how do these patients actually present? In reality, Beck's triad findings are rare and often a late finding. So some patients who have chronic illnesses that cause the effusion actually rarely present with the acute findings of chest pain, shortness of breath type of symptoms. There are many non-specific symptoms that are associated with tamponade. So they can present with cough, fever, hiccups, fatigue, abnormal vital signs. You may see pulsus paradoxus, for example, so greater than a 10 millimeter mercury drop in your systolic blood pressure with inspiration. But that's somewhat non-specific. You can see that with tamponade, and it's suspicious of tamponade when you're expecting an effusion, but it's also seen with emphysema and pulmonary embolisms and congestive heart failure and status asthmaticus and mitral stenosis, aortic regurg, and other forms of shock. So it's very nonspecific. And for reasons like this, point of care ultrasound is all the more important to assess for signs of tamponade and obstructive shock. So on this slide here, of course, on the top, you see a normal pericardium and then a pericardium with the effusion within it, within the sac. Below that, you see pressure volume curves of the normal pericardium on the left and a compliant pericardium on the right. So with rapid onset effusions in the normal pericardium, the curve on the left, low volumes that rapidly increase to a rise in pressure that exceeds the limit of the pericardial stretch with early onset tamponade physiology. So higher increases in volume acutely will acutely increase your intrapericardial pressures. That puts you at a higher risk of tamponade. On the right side, in a more compliant pericardium from chronic stretching, you reach a critical extramural pressure after much higher pericardial volumes, just because they've been slowly increasing and their stretch and their compliance is a little bit better. So they won't reach that tamponade positioning as quickly and as early as an acute accumulation. So with our chronic kiddos, our chronic effusion developers, it takes a high volume in the compliant or chronic pericardium to reach a point of tamponade, aka a critical intrapericardial pressure, highlighted by the line there and the arrows. Here's just some things that we can see at bedside when we're looking at pericardial tamponade. So on the left, you'll see signs of tamponade with maintenance of the aortic pressure with a mild right atrial pressure elevation seen by the arrow on the left with a loss of the rapid Y descent. So that Y descent is when the tricuspid valve opens in early ventricular diastole. And a loss of that Y descent means that there is restriction to RV filling, likely secondary to high pericardial fluid pressure that impairs inflow from the SVC and IVC to the right atrium and then to the right ventricle. So this shows that this pericardial effusion has started to cause problems with ventricular filling, and so these are some of the early signs that we see. Aortic pressure remains adequate or elevated by the top waveform because of increased sympathetic discharge or vasoconstrictive compensation within the body, but you can start seeing changes in your CVP waveform. On the right, you see an increase in your pericardial effusion that could potentially now be leading to a decrease in your pulse pressure and increasing tachycardia, all signs that we can see at the bedside with an increasing effusion. Here now, with the arrow on the bottom left over here, you see an increase in the right atrial pressure, mainly at the onset of the A wave or at atrial contraction. Your aortic and pulse pressure are significantly lower. And during inspiration, the arrow up here on the right, there is a further drop in the pulse pressure than during expiration, representing pulsus paradoxus. So this is all representative of increasing pericardial volume and thus leading to tamponade physiology. So what does all this look like at the bedside on ultrasound? So at the bedside, our probe serves as a very resourceful tool, especially when we know what we're looking for. So one of the first things that you look for is chamber collapse, and you can see that here in the ultrasound image highlighted by the arrows here. The right atrium and the right ventricle are collapsed secondary to a large effusion that is causing compression and impedance of cable drainage to the right side of the heart. With tamponade, you can see diastolic collapse of both the RA and the RV. You can also see respiratory variations in right ventricular and left ventricular volumes, as well as changes in the inflow velocities of your tricuspid and your mitral valve. And then during inspiration, the IVC remains dilated and its diameter fails to decrease, indicating systemic congestion. So normally during inspiration, your IVC diameter decreases. With a pericardial tamponade, it actually just remains dilated due to systemic congestion. Of course, there are other things to look for in the same region that may appear to be a pericardial effusion, so we can look at some of those. Pleural effusions are commonly seen on focused cardiac ultrasounds. It's important to be able to distinguish between a pleural ultrasound and a pericardial, a pleural effusion and a pericardial effusion. Both effusions can be seen as anechoic areas posterior to the left atrium and the left ventricle. In the parasternal long axis view, it's important to look at the location of the effusion relative to the descending thoracic aorta, which is highlighted in both of these images. Your descending thoracic aorta is present outside of the pericardium. So pericardial effusion will be restricted by the pericardium in the space that is anterior to the aorta, and pleural fluid will be seen posterior to the descending thoracic aorta. So on the left side here, you see that relative to our aorta, descending thoracic aorta, your pericardial effusion is going to be anterior, so above it. And on the image on the right, the pleural effusion is seen posterior to the descending thoracic aorta. So we'll take a look at an image next that will show both of them to be able to compare. So here's another example that was taken from a 2020 review in the International Journal of Cardiovascular Imaging. This is the parasternal long axis view where you can actually see both the pericardial effusion and a pleural effusion. Your descending aorta is here at the bottom right, and the pericardial effusion is anterior to the descending aorta in blue, and the pleural effusion is posterior to the descending aorta highlighted in green. We can also see an epicardial fat pad, which is fatty tissue that's located between the two layers of the pericardium. This can once in a while be misdiagnosed as an effusion. It can appear as an anechoic region on the ultrasound and occupies the potential pericardial space. But fat tends to have a more gray and isoechoic appearance rather than a dark anechoic appearance of an effusion. Also, you can see non-loculated effusions that potentially collect posteriorly in uncomplicated patients and uncomplicated effusions, but fat pads are typically seen anteriorly, such as in this image over here. So that's a way to differentiate in case you see something in the pericardial space. Sorry, here we go. There are some considerations when we're determining what to do with the pericardial effusion and whether it needs to be drained immediately or not. So, these are some questions that we ask ourselves. Is there cardiac tamponade that's causing hemodynamic compromise with a significant effusion? Are there treatment options for the underlying disease process that may actually treat the effusion or prevent the effusion from getting bigger without me having to do an intervention for the pericardial effusion? And do I need to, or very likely, do I need to treat that underlying process to prevent reaccumulation? What is the right option for asymptomatic patients with moderate to large effusions? And is this a chronic effusion or a recurrent effusion? So serial echoes, judicious fluid management, of course, are essential for the management of pericardial effusions. Now, serial echoes done by the cardiologist or bedside ultrasounds done by us, are important. You always want to consider treatment of underlying diseases, whether it's pericarditis, it's malignancies, autoimmune conditions like lupus, because that, again, might prevent reaccumulation. This ultrasound image here shows a localized posterior pericardial effusion labeled PE that is actually compressing the LV. The RV is also invaginated during diastole, and so patients like this will likely require pericardiocentesis entry from a modified apical window in order to drain this effusion in particular, because you can see the hemodynamic compromise that it's causing. When we're talking about interventions, so we're looking at pericardiocentesis, which some of us have been able to do at bedside, but many times, interventional cardiologists, interventional radiologists, or CT surgeons are also involved. The indication for pericardiocentesis depends on the level of hemodynamic compromise related to the pericardial effusion. Am I going to do a pericardiocentesis versus ask for an open surgical drainage? That always depends on the site preference and the experience of individual patient considerations. Percutaneous catheter drainage is a more common method, as long as there's an optimal window for pericardial centesis. But determining that optimal window depends on identifying the site with the largest collection of fluid, the shortest distance from the skin, and of course, trying to reposition a patient to redistribute the fluid collection and find a target window is essential. But in some of our younger kids, and actually even in our older kids, a lot of these patients will need to be sedated in order for us to be able to get a good technique to reach the effusion. Sang et al. In when was this? In 2002, I believe, had published a 21-year retrospective review that demonstrated 97% success rate with ultrasound guidance. And they had shown that the apical approach was the most frequently utilized location in about 68% of the cases that they looked for. They say that it allows better visualization of most of the effusion using the apical approach. And then just considering some complications that can happen of a pericardiocentesis: hemothorax, pneumothorax, hepatic splenic injury, gastric injury, cardiac puncture, infection, arrhythmias, pneumopericardium, pneumomediastinum, and of course, entering a cavity or a ventricle is potentially also a complication if we're doing percutaneous insertion. So the different approaches, you have the apical approach, which the needle is directed parallel with the long axis of the left ventricle towards the aortic valve. You can also do the peristernal approach, where a puncture is made 1 centimeter lateral to the sternal edge to avoid any puncture of internal mammary artery or a pneumothorax, but you can insert peristernally. And then the subxiphoid approach. So the needle is inserted 1 centimeter inferior to your left xyphocostal angle and aimed towards the left mid clavicle. I personally have not done the apical approach. I have seen the apical approach being done by our interventional cardiologists, and I have only tried the subxiphoid approach, as that's the way I was trained, and have done it about 4 times using subxiphoid approach. But next one, I think Dr. Ali and I, who's here, can do the apical approach. When using ultrasound guidance for a pericardiocentesis, you want to make sure you can orient and insert the needle in a frame that's parallel to the ultrasound beam so that you can get an in-plane view of the needle. So it's hard to see in this image, but this is one of our pericardiocentesis that we did here. You can see where the arrow is, that the needle is trying to insert into the pericardial space. Ideally, you'd like to have real-time ultrasound visualization of the needle passage, but this can be difficult. At times, it's difficult to aspirate fluid as well. So if you get blood in your syringe as you're advancing your needle, which actually is a very scary occurrence, believe me, you wonder if it's hemopericardium or accidental cardiac puncture. So it's definitely very important to monitor hemodynamics through the procedure, and also to utilize your ultrasound skills to be able to track your needle as you're inserting as best as possible. Here, this is actually the wire. So I'm sorry, it's a very blurry image, but where the arrow is, you can see this is where one of our patients, we had inserted the wire as we were doing a percutaneous insertion of a pigtail in this patient. So that's where the wire is, to confirm that the wire is actually sitting there in the pericardial space. So one more question. A 16-year-old male has been admitted to the PICU for 3 days now after septic shock secondary to strep pneumobacteremia. He initially presented with refractory hypotension. He required 100 mLs per kilo of fluid resuscitation in the first 6 hours of admission, followed by epi and norepi drips. He is now improving. He's off norepi. He's weaning epi. You are concerned for fluid overload and wish to start dialysis. The nephrology teams comes to bedside while you are performing your focused cardiac ultrasound and ask what you see. What do you see based on this image? So hopefully everyone's had a chance to answer, but in patients like this, we're looking at your descending thoracic aorta, which I probably should have labeled here, I'm sorry, but is in the middle, is that anechoic circle in the middle of the image towards the bottom. You see anterior to this descending thoracic aorta, you see your pericardial effusion, and posterior to it, you see a beautiful pleural effusion as well, probably related to this patient's extensive fluid resuscitation that he required for his septic shock. So C would be the answer for you seeing both a pericardial effusion and a pleural effusion in this patient. So back to our case. Our patient was found to have a large global pericardial effusion after the cath procedure. So this is the patient who was a single ventricle, who went home, came in desatting, got intubated and taken to the cath lab, stented the BT shunt, and after coming back, started to have hemodynamic compromise, hypotension, elevated LFTs, elevated creatinine, INR up to 3.8, and now requiring vasopressor inotropic support. And that patient ended up having a large global pericardial effusion, likely from a right atrial microperforation from the guiding catheter trying to get through a very small PFO in this patient. Our effusion was evacuated at bedside with a pericardiocentesis and drain placement, and frank blood was evacuated. And that was because this was a perforation through the right atrium rather than us, cannulating the LV, RV, thankfully, RV in this patient. And we noticed a marked clinical improvement immediately afterwards. So when you have pericardial effusions as a complication of an intracardiac procedure, the effusion's usually from a perforation that may develop quite rapidly. And that perforation can be caused by a guide wire, a dilator, sheath, a balloon, a guiding catheter, pacemaker lead, or even excessive ablation injury. And so the presentation, of course, of the effusion depends on a few factors. What was the size of the device that caused the perforation? What was the structure that was perforated? Was it atriomyocardium or ventricular myocardium? What was the hemodynamic state of the patient at the time for a perforation? For example, a small right ventricular perforation in an unanticoagulated patient may actually not be a problem, but a small right ventricular perforation in a patient with pulmonary hypertension, with a very high pressured ventricle, or a patient that's fully anticoagulated can actually be quite dangerous. Or a small perforation, guide wire perforation in the LV may be okay since the thicker LV wall can seal small perforations. But in the setting of LV outflow obstructions, like with severe aortic stenosis and very high LV pressures and high afterloads, this perforation can be allowed to serve as a pop-off valve, leading to an increased risk of tamponade. So your situation really depends on what is the clinical status of the patient, what was perforated, and in what setting. The state of the pericardium. So for example, after cardiac surgery, the pericardium can be absent. It can be adherent to the myocardial reflection, and that can prevent the development of a tamponade, but it can still occur posteriorly, which is quite difficult to reach. And so in cases like that, we're asking for help of our CT surgeons, who may need to figure out a way to get this effusion if it's causing problems. And then of course, coagulation status in these patients. This patient developed a INR of 3.8 with his systemic congestion, and that definitely did not help the situation. There are some limitations to our point of care ultrasound or our focus with limited windows, poor quality images. It's definitely operator dependent. So the more we practice, the better we develop our skill. And then, we're limited by a standardized approach to train providers. As much as we want to train our trainees with bedside ultrasound techniques, we can do that. But, performing a pericardiocentesis under ultrasound guidance is actually a very rare procedure to have. And so many people actually do graduate fellowship without getting the opportunity to do that. But it is something that could be standardized. So we are training providers all across the board. And then just some last minute, conclusions. Point of care ultrasound and focused cardiac ultrasound techniques are widely used. They're feasible, they're reliable, they're reproducible. Early suspicion of pericardial effusions and early detection of tamponade is absolutely essential. And there's various techniques of pericardiocentesis using ultrasound guidance available to optimize hemodynamic stability.